Gastric cancer. So, in gastric cancer, we begin with the discussion regarding the etiology or the most common risk factors. So, which include your H. pylori, pernicious anemia, gastric atrophy, peptic ulcer surgery with drainage. We had discussed this even in the peptic ulcer part, where these are considered as an independent risk factors for your gastric carcinoma, and gastric adenomatous polyp. Now, with respect to polyp, a very short topic over here which we would discuss is the most common type of gastric polyp is your metaplastic polyp. Now, the polyp associated with your proton pump inhibitors include your fundic gastric polyp, and also the polyp which is associated with your familial adenomatous polyposis is your fundic gastric polyp. Right. Now, cigarette smoking, excessive salt intake, exposure to N-nitroso compounds. So, these are your some of the risk factors for your gastric carcinoma. Now, they may how does this gastric cancer present? We have already discussed in your gastric outlet obstruction, right, that it may present as gastric outlet obstruction, and other features would include your bleeding, early satiety, bloating, distension, and the non-metastatic effects like your Trochu sign. So, what is this Trochu sign? This Trochu sign is your thrombophlebitis, and it may also present with your deep venous thrombosis. Then, regarding your most common site in the west, it is your proximal stomach cancer. Right. Then we have a most commonly clinical use classification in your gastric cancer, which is your Laurin classification. So, this Laurin classification defines your gastric cancer into two types, which is your intestinal gastric cancer and your diffuse gastric cancer. So, this intestinal gastric cancer, they form the polypoid tumor or ulcers, whereas this diffuse gastric cancer, they infiltrate deeply into the stomach without forming any obvious mass lesions, right, and they may be associated with your signet ring cells. Now, early gastric cancer. So, what is your early gastric cancer? Early gastric cancers are those which are limited to mucosa or submucosa, which may be with or without lymph node involvement. We have a classification for your early gastric cancer, which is your Japanese classification. So, if you look over here on the left hand side, we have the diagrammatic representation of your Japanese classification, and on the right hand side we have your endoscopic images of the various types of early gastric cancer. So, if you see in type 1, we have your protruding type of early gastric cancer. Then type 2A is your superficial, which is elevated, and type 2B is your superficial flat. So, again let me write it on. This is your protruding type. Then we have your type 2 superficial, which is elevated type. Then this is your flat type. Then we have type 2C, which is your depressed type. And then we have type 3, which is your ulcerated type. So, if you look over here, we have early gastric cancer in type 1, where you find a protruding mass. Then you have a type 2A, which is your superficially elevated, and in type 3, which we have over here, is your ulcerated mass. Now, we have your advanced gastric carcinoma. So, advanced gastric cancer, they basically infiltrates your muscularis. So, there is a classification system for your advanced gastric cancer too, which is your Borman classification. So, if you see over here, you have your type 1, which is again your polypoid classification type. Then you have type 2, which is your ulcerating type. Then you have type 3, which is your infiltrating type, and you have type 4, which is your linitis plastica. So if you look over here, oh, image A shows you the polypoid type, image B shows you the ulcerating mass, image C shows you the infiltrating part, and your image D shows you the entire linitis plastica. Now, with respect to the molecular pathology, the 4 molecular subtypes of gastric cancer that have been identified, which are your EBV positive, microsatellite unstable, and genomically stable, and your chromosomal instability. There are various of gene mutations involved in it. So we could be discussing one of your table and charts later on, which would show you a common type of gene mutation associated with gastric cancer. I think that would be sufficient to remember rather than remembering a lot many of genes for your gastric cancer. Then regarding the spread, now they usually spread directly involving your adjacent structures, or it could have a lymphatic spread. In lymphatic spread, we have a Trocheus sign, that is your involvement of your supraclavicular lymph node. Right. Then we have a bloodborne metastasis. The first one occurs to your liver, and then the transperitoneal spread. So we have your ovaries, where they have your Krukenberg tumors, right, and in your umbilicus, which is your Sister Mary Joseph nodule, right, and they are best detected by your laparoscopy. Then regarding the staging of gastric carcinomas, we have TIS, which is the carcinoma in situ. T1A, it's invading your lamina propria or your muscularis mucosa. T1B invades your submucosa. Then we have your T2, which invades your muscularis propria. Then we have T3, which invades your subserosa. T4A is your visceral perforation, that is perforation of the serosa, and T4B is your invading adjacent structure. Then you have your N nodal staging. N0 is your no nodes involved. 1 or 2 regional nodes involved is N1. Then you have N2, which is 3 or 6 regional node involved. Then if you have 7 to 15 regional node, that would be your N3A, and N3B would be 16 or more regional node. So this lymph nodes involvement and that which lymph node is involved has been discussed in your surgical anatomy part of this stomach section, right? And the M0 is your distant metastasis, and M0 is no distant metastasis, and M1 is your distant metastasis. Now, what are the features of your incurable disease? It includes your hematogenous metastasis, involvement of distal peritoneum, M1 nodal disease, and fixation of structure that are not resectable. Now, in case of an operable disease, the treatment would include a total gastrectomy. So, in what happens in a total gastrectomy, stomach is removed and blocked tissue with greater plus lesser omentum. You have a resection margin that needs to be taken around 5 cm, and the GI continuity is maintained with your Roux and Y loop. Now, the minimum length of the elementary limb should be your 50 cm. Why? To prevent the bile reflux esophagitis, right? Now, if you look at this is your image of your radical total gastrectomy, where they have this image has been shared in your Bailey and Love textbook. So if you see over here, the step 1 over here. So what it is your dissection of the omentum from the transverse colon. So if you can see over here, the omentum is being dissected of the transverse colon. Then we have your step B over here, where your lesser sac is being exposed. Where your lesser sac is being exposed. Then we have your type C, where they have a splenectomy is being performed in cases where it is needed, right? Then in type 4, we have your division and the overswing of the abdomen, of the duodenum, sorry, not the abdomen, overswing of the duodenum. And then we have your type 5, where you have your dissection of the left gastric artery group of lymph node, and you have F, where you have your mobilization of the esophagus being done, right. So these are your steps that have been demonstrated in your Bailey and Love. And regarding the lymph node dissection, we have your D1, which is your removal of perigastric lymph nodes, right. And then this D2 is your lymph node moved, or which is removed along the major arterial trunks. Now regarding your role of your subtotal gastrectomy, it is usually done for your distal tumors. The palliative surgery is done when tumor presents with bleeding or obstruction, and palliative radiotherapy is done for your painful bony mets. Then the complications of your gastric surgery would include your anastomotic leak, right. So this patients would present with postoperatively with tachycardia or pain abdomen. Then it could present as a duodenal stump blowout, where it may be presenting as your biliary peritonitis, and in terms of nutritional deficiency, it may present to you with vitamin B12 deficiency. And now we end our gastric cancer with the last topic of discussion, that is regarding your neoadjuvant chemotherapy. So earlier the platinum based triplet regimens were used, which included your epirubicin, cisplatin and 5-fluorouracil. Recently FLOT is being used, which consists of fluorouracil, leucovorin, oxaliplatin and doxycycline. Now on one trial which I would want you all to remember regarding the perioperative chemotherapy, that is before and after surgery, is your MAGIC trial, right. So this were the important points and concepts that I wanted you all to remember in gastric cancer. Thank you.